Hey Alshad, nice poster.
Oh, thank you.
How are you doing?
Doing great.
Far away from Houston, huh?
Yes, exactly.
So looks a pretty interesting poster here.
Thank you.
So how do you get interested in nuclear medicine? It's a little different from your main core topic of medical oncology, right?
Yes. Now, when you say nuclear medicine and the drugs that can induce the immune system, that's where we have some favorism that how we can combine them with the immunotherapy to hopefully help more patients. And it was the beginning of the story, and we realized that, well, there's really a growing area that now we can use the antibody radioisotope conjugates to generate the local inflammation in the tumor. And here the drug that we have is lutetium girentuximab. Lutetium is targeting the CA9, and CA9 is expressed on the renal cell. It's one of the best membrane markers actually under the microscopy that we use very often. And the reason that CA9 is expressed in renal cell carcinoma is driven by the DHL loss and also by the hypoxia in general. So that you have a CA9 expression, girentuximab is targeting the CA9 antibody, releasing the lutetium locally in the tumor microenvironment. And this local radiation, which there's a lot of research with SBRT combination and other things that can induce the DNA damage. And the DNA damage releases the cytoplasmic double-strand DNAs. And evolutionarily, we're built to protect our body from the double-strand DNA break to protect us against the virus by inducing the innate immune pathway, the C-gastin pathway, which is inducing the inflammatory response. And now we mimic that and we generate the DNA damage, inducing the C-gastin pathway, which is releasing a lot of cytokines, asking for the immune system to come and help to fight against the disease. And when you have the immune system coming there, of course, many of those T cells will be expressing the PD-1. And the goal here is to use the currently approved standard of care nivolumab plus cabozantinib that can help to block the nivolumab access and also use the cabozantinib, which is a multi-TKI.
So we call this approach Theranostics, right?
Yes.
Combining a monoclonal antibody with a radioisotope that can use diagnose and treat. And so it's cool that now you're trying to use this Theranostics approach in combination with chemotherapy. So
with
immunotherapy, sorry, yes, not chemotherapy per se. But I think this is good. We need more of these studies to see where, in the grand scheme of things, where different things fit in the sequence of treatments, and if we can do combination therapy.
Yes.
What are your thoughts on that?
Yes, definitely. I think this is like we already have data from the lutetium PSMA in the prostate cancer. I think this is going to be really important. I mean, more than probably before, because now we have the immunotherapy which can synergize. There are a lot of studies that has been published with radiation, SBRT plus immunotherapy, which is showing that we can generate immune response. However, thinking about if someone has 10 metastases, it's really challenging that we will have radiation to all different sites of the body. But it's a nice approach for the oligometastasis, which our group actually has done studies on that. Now, this concept is actually taking it one step further, that now you will give a drug that's going to go all metastatic regions and generate a local radiation. So that's the hypothesis that we have here. And we are also doing a lot of biomarkers, which is supported by the DoD grant that will help us to understand what is the effect of the lutetium only in the tumor microenvironment, what is the effect of lutetium plus nivolumab and cabozantinib, that's a biomarker cohort 2, and the third cohort, what are the resistance mechanisms? And of course, we expect that some of the patients will have a resistance, but hopefully this biomarker studies will help us to identify resistance mechanisms. The next study, we can really change one of the players here and add that to prevent the resistance.
Excellent. Looking forward to your data.
Thank you so much. Thank you. Really.
Thank you.
Thank you, Amal, for visiting.